recording, and let me recording also. Okay. Thank you very much, everyone, for joining the sessions. And I've seen there are a few of them are waiting also. So let me introduce myself. My name is Dr. Kashif Chauhan. I'm one of the pediatric surgeon working in Nottingham, UK. And this is our regular teaching session, which we do regularly in collaboration with the federal government of Pakistan and with the other associations also. On this teaching session, I am also representing the Association of Pakistani Physicians and Surgeons of Europe. I'm one of their founding board members, and I'm also representing the NODFA Association, which is the National Overseas Doctors Family Association. And I'm also thankful to the federal government of Pakistan, their Yara Ne Watan program, and the federal minister for allowing us to live telecast it on their website as well as on their portal also. The topic of our teaching is related to the orthopedics today. This is the first time that we are doing this orthopedic session, which we thought is one of the most important sessions. The topic which we are going to discuss is COVID-19 pandemic and its effect on orthopedic surgery, basically hands and shoulders. I'd like to introduce our two very esteemed speakers. Both of them are consultants. Both of them has recognized their name, has put a recognition for their country as well as for themselves in different parts of the world. Let me introduce you first to our senior consultant, Dr. Yasser Khan. Dr. Yasser Khan, if you could just wave your hand so that they know that this is you. Uh,
That's me, yeah.
He's the founder and the chief executive officer of YK Orthopaedics Sports Medicine and Rehabilitation Center in Karachi. He got his post-graduation from Ireland and then got further training and education from United Kingdom, Germany, Russia, and Spain. So he has done quite a lot of further fellowships in those, from those countries. He's a highly qualified orthopedic trauma and sports surgeon and has got over 20 years of experience. He worked as a consultant orthopedics in trauma and sports in Ireland, Saudi Arabia, and currently working in Pakistan also. So thank you very much, Dr. Yasser, for your valuable time.
Thank you.
I know
Thank
you
you
are
for the
fasting,
invitation.
and the fasting will break in the next 50 minutes, so we won't take your time. But I'm extremely grateful on the behalf of the Association of Pakistani Physician Surgeons and NODFA for your time. The second is Dr. Sami Hassan. Dr. Sami Hassan, I know this young surgeon for a very long time when he was training, and I must praise him the way he has progressed in his career, the way he has achieved the thing is such a tender age. It's amazing. So, Dr. Sami Hassan, thank you very much. If you could just wave your hand so that people know that it's you. So he is a consultant orthopedic and hand and wrist surgeon. In 2019, he became one of the only few surgeons worldwide who has completed both the British and European Hand Society's diploma. He graduated from University of Sheffield in UK and then did his prestigious fellowship in hand and wrist surgery at Chelsea and Westminster Hospital in hand unit. And believe me, they are regarded as one of the best teaching and training units in hand of the world, because I know quite a few of people who tried to get in to do that fellowship and they were refused. He also worked at Pulvertoft Hand Center in Derby, which is also regarded as one of the best. He was awarded the BSSH Traveling Fellowship Award in 2015, and he has done a further training in the University of Stanford, California in hand and upper limb surgery. The excellent thing about Sami is that he conducts regular teaching sessions for the intercollegiate FRCS orthopedic exams also, and especially help the foreign graduates. So thank you very much, both of you, on everybody's behalf. So the format is that we're gonna start our teaching session, which will last for about an hour. And after the teaching session, if anybody has got any questions to ask, please write it down in the chat section, and I will take it, one by one. So Dr. Sami, I will give the speaker to you to start your presentation.
Okay, thank you very much, Dr. Chauhan. Thank you very much. 1 second, I'm just going to fire up my PowerPoint. So, good afternoon, everyone. Good evening in Pakistan, and Ramzan Mubarak to everyone joining, and for the telecast via Facebook. Many thanks for the very warm introduction by Dr. Chauhan. And today I'm going to talk generically about hand surgery, the training pathways available currently, and the changes in them. I'm going to talk about how hand surgery has evolved over a period of time, as well as how it's been impacted by the COVID-19 pandemic over the last 18 months or so. So moving forward, first and foremost, we're going to have a look at hand surgery, how you can get into hand surgery, what's the training pathway. We're going to have a look at how COVID has impacted our service delivery in the NHS, how we've adapted to the pandemic, and more importantly, we'll talk about ways of innovation and what we've been doing to make it more safe to work and to provide operations for patients suffering from both elective and trauma conditions of the hand and wrist. Finally, we'll present some evidence to say how safe upper limb surgery has been during the COVID-19 pandemic. Oh, excuse me. So just a quick disclosure, I'm a founding chairman of the Orthopaedic Network, which is a non-affiliated group, no financial affiliations to anywhere else, but we provide education, as Dr. Chauhan mentioned. So hand surgery itself is a multidisciplinary specialty. It deals with conditions affecting both the hand, the wrist, and all the nerves from the peripherals coming from the cervical spine down to the tips of your fingertips. It's an integrated specialty, and it relies on skills from not just orthopedic surgery, but plastic surgery and emergency medicine. And we work as a team like they do in all aspects of medicine, with great input from our rheumatologists, neurophysiologists, pain medications, and even the psychologists. The backbone of hand surgery is our hand therapists, and they form a massive, probably the majority part of treating all of the hand and wrist conditions that come to us, either with its direct treatment or whether it's post-operatively for surgery with the aim and goals of improving function, range of movement, and going back to activities of daily living. So, as a hand surgeon, we have a broad spectrum of training. We deal with broken bones, open injuries, closed injuries. We deal with the multiply injured patients, but also deal with small finger fractures and soft tissue injuries like replantations of digits. Hand surgery worldwide is evolving. It's like medical education never stands still. And various parts of the country, for example, the States, people can get into hand surgery from being general surgeon. In Europe, there is direct training pathways for hand surgery, but in the United Kingdom, there is a traditional system in place where you do your house or your internship, moving on to sort of an SHO post where there's specialist core training, and then you go on to do a 6-year residency program, which would either be orthopedics or plastic surgery. Once you've gained your CCT, which is your completion of your training, you move on to do hand surgery fellowships with specialist dedicated fellowships post CCT around the country. There's also posts and availability to go abroad, and more coming out. The young hand surgeon generation, it's accepted that hand diploma, both from the University of Manchester for the British Hand Society or the European Board, is now becoming a prerequisite, allowing one to transfer both the knowledge and the evidence base to your clinical practice. So COVID-19 hit us, sadly. Things changed quite profoundly for the turn of 2020, and especially in March, when the United Kingdom decided to go down towards the lockdown route. And being and working in the NHS, there were a huge amount of changes that took place at a very speedy way. People were amalgamated, SOPs were changed, and patients were readily discharged from hospital in view to the sad onslaught of attendances for patients coming in with COVID-19. So moving from a very relaxed environment in hospital, working very casually and adhering to no such SOPs, we moved to a position when we are working in strict personal protective equipment. We're working in difficult circumstances, and life as it was has such change in the working environment. We are now far more working in teams, working with other multidisciplinary teams and other subspecialties in delivering care, and at times outside our comfort zones. So how did the Orthopaedic Society change its practices? So towards the end of March 2020, the British Orthopaedic Association developed this paper and essentially outlining the need to change our practices due to the emerging conditions that we're having in hospitals. Treatment choices had to be made in regards to the benefit of the patient, whether coming into hospital and being possibly exposed to COVID, or dealing with a fracture which could potentially be treated later on. And it became a balancing act for the clinicians. The BOA developed this proforma to aid and guide all subspecialties to make these decisions, which at times are tough, which may in the short term not be in the interest of the patient, but in the long term, for a public health point of view, and B, for the patient and its relatives who live with them, a better thing during the pandemic. This is an example of what they decided in hand surgery. It's a very wordy document which I've pasted on, but essentially it found a framework on how we are going to work in the short term, and I'll elaborate on that in the coming few minutes. So not only did it affect hand surgery, it even infected routine things such as hip fractures, and papers have now coming out all over the last year, and it said, you know, inpatient falls increased whilst you're in hospital, the mortality increased for patients with regards to having hip fractures. They moved from approximately 10% mortality with a hip fracture to approximately nearly 37%. So things had dramatically changed over a very short period of time, and we did have to adjust. Moving back to what we did on a ground reality thing, SOPs, like they are everywhere in the world, came in. Hospitals became a one-way traffic system. As you entered one way, you exited through another door. PPE and all the changes that have developed through them, from very basics to ones that protect you from aerosol generating procedures, have all evolved. Social distancing both became the norm within the hospital community as well in the public. Sadly, the most sad thing of all were no visitors were allowed to the patients that were coming into hospital. Some of these patients were maybe not very sick, some very, very sick. And having family and friends to visit them is an essential part of their mental well-being. And this was the saddest thing to see, not to see relatives coming into hospital, but as per guidelines and public health benefit, this was the needs must. Even simple things like hospital shops and cafeterias had to close. Junior doctors are redeployed. You know, trainings had changed. We had our junior doctors moving on to a medical rota, our RMOs going to do nights in medicine, helping out on the shop floor in the emergency department. Elective orthopedics was the first to shut down as theatres became intensive care units with ventilators. The elective services had a big pause in them and have massively affected our community with people's quality of life. People who are living with osteoarthritis and and neuropathic pain they've been living on for the last 18 months without any surgical intervention. Is now surely and slowly we're starting to resume some elective activity. In regards to being an orthopedic consultant, we changed. Our SPA sessions became based at home. We became predominantly trauma commitment led. We were working in the minor injury units with the emergency department nurses to make sure it's streamlined. Patients are seen early, patients are seen once, and they have a definitive plan as opposed to coming in and out of hospitals. We got redeployed in the intensive care unit, helping with proning patients who are quite sick and on ventilators for purposes of adjuvant oxygen therapy. So how did we adapt? As a department, we're a very adaptive bunch. Medics are very good at dealing with problems, compartmentalizing, and finding a solution to issues. And very fast, hospitals around the country, including the one that I work in, were wonderful and expedient in changing how practices happen. We, even prior to our changes for COVID-19, we used a virtual fracture clinic. Anyone that came in with some trauma, the emergency department essentially reviewed them and subsequently referred them to TNO via this online virtual platform. The following morning, the orthopedic consultant, if it's a non-urgent thing, will go through all the x-rays and notes and appropriately triage those patients depending on to specialty specific diagnosis. So if exactly they came in with a hand injury, they'll come into my clinic. If they came with a soft tissue knee injury, they'll go to the knee surgeon's clinic, and so on. And therefore, from that point onwards, we changed our practices even with virtual fracture clinic. We were discharging patients straight to physio. We were giving them telephone advice. We were limiting the attendances to hospital. Our hand therapists, which make the backbone of hand trauma, they were seeing patients both virtually and face-to-face and avoiding necessary or unnecessary or over-operating, should I say. Face-to-face consultations still took place, but only the patients that needed a clinical examination or x-rays that were ambiguous or documentations that needed further investigating. Patients that needed surgery were all brought back to clinic, and manipulations were the way forward, like it would be when you don't have the facilities of a first world surgical unit. So hand surgery, it's a very unique subspecialty, and we run, majority of the patients that have a hand operation go home the same day. We run a day case system. It doesn't matter whether they have a 6-hour operation or they have a 25-minute nail bed repair. They all go home, majority of patients go home, and we're a specialty that's actually quite well adapted for a crisis, even a pandemic, one may say. Day case surgery enables the patient to have an operation and to go home the same day, which benefits, especially in the COVID pandemic, where there's limited amount of patients in hospital, limits the chance of contracting COVID both in and out of hospital. Hand surgery is based by regional block anesthesia, and got to commend our anaesthetics anaesthetic colleagues working very hard with this. This avoids the need for general anaesthetic, no aerosol procedures, and once the patient's had a COVID swab and they're COVID negative, we can proceed to majority of surgery unless emergency or urgency surgery. Hand therapy has always been a forefront, as I keep reiterating, and those became virtual and face-to-face became slightly limited. We treated patients with splints, plasters, and although the x-rays may not look the best, the aim of treatment at that point was early rehabilitation and to optimize function. So, second reason why hand surgery is a very adaptive subspecialty. Majority of hand injuries, such as fractures and closed injuries, can be treated non-operatively. Boxer's fractures, such as the fifth metacarpal neck, those are well known and can be treated non-operatively, quite common injuries, and other finger fractures are treated non-operatively with early rehab and hand therapy input. So how else did we adapt? We developed minor ops theatres. We developed the ability of doing manipulations of wrists and distal radius fractures and fingers. In our unit, we're very blessed. We've got 2 mini C-arms, and we removed one of them into our lead-lined room in our clinic. And anyone that presented who had a distal radius fracture, for example, we were able to perform a manipulation using a block and using X-ray guidance to get perfect X-rays. Having this machine in situ really helped, and it provided patients with the opportunity to getting treatment done without having necessarily needed to be admitted into hospital or having surgery. Having set all these things up and having had the funding for this, it can now be used to develop minor ops theatres moving forward and help with our elective services. Having an X-ray machine such as this allows us to provide corticosteroid injections. I even perform carpal tunnel surgery, Dupuytren surgery, and trigger finger surgery, which is routine day case operating in these minor op theatres just in clinic. So, how is hand surgery revolutionized? I think one of the key things which has now taken full flow is wide awake surgery. By wide awake surgery, it means we don't use regional block or general anesthetic, and we use something called WALANT, wide awake local anesthetic, no tourniquet. And this has been pioneered by Don Lalonde up, I think it's in Canada, who's been using it for years, and it's come across transatlantic. And we've started really pushing this out and using adrenaline mixed with local anesthetic, and doing majority of our surgery that way has prevented in the COVID pandemic aerosol generating procedures, and therefore putting staff and people at risk from contracting the COVID virus. So it was initially started in 2015 when it was presented in America, but now it's being used worldwide, and it's now forming at least a small part of our practices. And going forward, I think this is the way forward. It helps both with easing work pressures, personnel pressures, and allows us to redirect the anesthetic and ITU teams to also be redeployed in areas when at time of need may be necessary. Simple procedures such as this: carpal tunnel, trigger finger, PIPJ fusions, metacarpal phalangeal fusions, Dupuytren's contractures, and metacarpal fractures can all be treated under local anesthetic, which historically everyone was having general anesthetic. The advantages, not only intraoperatively, we can ask the patient to move their hands, and we can see how well our fractures are fixed, how well our tendons are repaired, and it is revolutionized and will revolutionize further the way we think about hand surgery. Interestingly enough, Amir Adnan's one of the people in the forefront of this, a surgeon from Malaysia, who's been painting distal radiuses, and recently a paper published even from Pakistan has shown this technique is starting to move across the world, and this paper is recently published in the Bone and Joint Journal in 2020, and notices how well patients are doing with this. It's not only a operation that absolves having an anaesthetist present, but also allows for faster recovery, early rehab, and outcomes have been excellent, at least from that unit that has been known. It's also very cost efficient. If you work in a hospital that has limited resources or resources that need to be redirected, it's a very cost effective way to redirect anesthetic resources elsewhere. Let's move forward. So how safe is hand and upper limb surgery during the COVID-19 pandemic? Multiple centres from the United Kingdom participated in the COVID hand, or the Corona hand study by Ben Dean from Oxford. One of them was our unit, and they analysed 1,093 patients who underwent upper limb surgery. And they said the mortality from doing that and having it during the difficulty period was 0.09%. That's a lot of patients with a limited morbidity, thank God, limited mortality. In conclusion, the study from around the country noted that the complication rates and the mortality rates are pretty much zero for patients having day case surgery, and even states the fact that urgent surgery should not be delayed for a COVID-19 swab result. So this goes back and also highlights the fact that hand surgery is very well adapted. The day case model worked very, very well. and established units with having day case surgery units in place, did really, really well from this, and obviously limited the chances for mortality and complications to occur using this type of service. So how's teaching and training changed? This has also impacted all surgeons and all doctors from all subspecialties, whether you work in the community or whether you work in pediatrics. We are no longer able to attend and be faculty at various meetings from around the world. We can't present. And however, we have had the benefit of technology, virtual teachings, and how things have changed is that there's a wonderful amount of lectures and material out there on YouTube. Hand surgery, the Pulvertaft hand seminars have been absolutely wonderful. World leaders of hand surgery have been going on and putting their videos on, which keeps us up to date, keeps our knowledge to the cutting edge, and allows us to provide evidence-based practice to our patients. So I'm going to leave you at this point and say thank you very much for listening to me. And I'll look forward to your questions towards the end. Thank you.
Thank you very much, Sami. That was a very impressive, very detailed thing which you have explained it to me. Even me, as a working in United Kingdom, I don't know the things you have explained it to me. And the good thing is that the paper you have mentioned, which has been published from Pakistan, it means that the countries like Pakistan are in line with the pace UK or the other countries are moving. So that's a very, very good thing. So thank you very much for that. I've got a few questions for you, but we'll take the questions at the end. Now, can I give the mic to Dr. Yasser Khan, who's a senior consultant in orthopedics, to just give his presentation, please. So, Dr. Yasser.
Assalamu alaikum. Kaise hain sab log? How's everyone? Thank you, Kashif and NODFA and Yaran Watan and my lovely Pakistan for giving me this opportunity to present to you what I believe is happening in orthopedic surgery, in particular around shoulder area under this pandemic. Right. So let me start. I have nothing to disclose except that we are still living in the pandemic, and that's not a good feeling, right? And we know that this pandemic has placed the whole world and the medical profession in particular in an unprecedented situation. I mean, the hospitals are choked. There are news even today all over the world that people are dying because of lack of oxygen in India. And the beds are completely filled in Pakistan, parts of the cities of Pakistan. We are in the third wave as we classify this pandemic into waves. So the first wave started from China, Wuhan, and now we are into third wave affecting different parts of the world. Initially, it's thought to be a respiratory disease, but we know now that it's not. It affects different parts of the body, and it could be a very tiring experience if one is turned out to be positive and living through this virus, quarantine for 2 weeks, and then recovering from it. So what actually happens? If we look at it, a lot of patients are complaining of chronic pain, and the high risk of acute pains could be someone who's already has pre-existing pains like shoulder pain, which has been there. He got a COVID, and his shoulder pain got accentuated, got worse. The people are particularly at risk of receiving this chronic pain are those with pre-existing medical conditions like people with diabetes, people with hypertension, heart conditions, and people with mental conditions are really suffering with this pandemic. We have a lot of rehab challenges to face during this pandemic with everything is closed. we have the neurological insult, and other causes. So what exactly happens? Why is that? What happens? What does this COVID virus has that causes all these changes in one's body? So if we look at closely, we call it as is a cytokine storm syndrome. So what actually happens when you have a COVID? There are inflammatory cytokines that releases and really attack your system, different parts of your body system. The most common till now we know the systems apart other than the respiratory system are the shoulders and the back. So a lot of people will be complaining about the shoulder and the back pain. And someone who already has a pre-existing shoulder issue, his pain will get worse. So I've just put this slide just to give you a brief. So you have this healthy shoulder where you have your subacromial space and your rotator cuff lying around and the capsule around it, and you have kind of rotator cuff tendonitis or kind of a mild early frozen shoulder start of problem with the capsule of the shoulder joint. We call it adhesive capsulitis as well. And with this COVID, you got a cytokine storm syndrome in your system. The system, when this syndrome hits your system, it recognizes the problem, pre-existing problem, and it attacks that particular part of the body ferociously. So you would suffer and you would have a lot of pain from this this cytokine storm syndrome. And this is an MRI shared by the hospital in Illinois. So this patient had a bit of a normal shoulder pain, but then he got a COVID. The cytokine storm syndrome hit him, triggered rheumatoid arthritis in his system. And you can see that he got severe shoulder pain. And this is his MRI showing to you now. So with all this going on with the COVID, what really happened to the orthopedic world? Well, how did the COVID impact it? We were put off the job. The clinics closed, the trauma theater closed. We were assigned, because we were not the first line workers, so we were assigned into different wards, as Sami just mentioned, that his residents were given tasks to help their medical colleagues, and fair enough, they have to. But it also means that a lot of those patients sitting at home, suffering with shoulder or wrist or knee problems, were still suffering because there's no one to take care of them. And if you look around the world, I'm putting up some articles here from British Columbia. Their surgery cut down, canceled for most respondents. 40% were afraid, the surgeons, 40% of the surgeons were afraid that they will infect their either family members or their patients, and 25% of them admitted that they started to drink more heavily. And just cancellation during the first wave, the backlog of surgeries in British Columbia was 32,400 patients waiting to go through, be admitted in the hospital and go through the elective procedures. We look at, okay, I don't know why it's not moving. It should move. It's got stuck. I don't know. Okay, so now, so if you look around the Turkey, 75% decrease in surgical and outpatient activities. So again, the hospitals are shut down, the clinics are not working, and we have to think fast and think really fast. What about UK? 91% all elective operating canceled. Trauma continued as normal, but the trauma burden was low because there's no one out on the streets. There are no kids falling off the trees. There were no one twisting his ankle playing football and breaking his tibia and fibula or ankle joint. So the trauma still continued. 55% reported that their clinics were completely canceled. 55% of orthopedic surgeons, consultants. like Sami. Their clinics got canceled. 38% reported elective clinics were running at a reduced capacity, and they have to try their patients, who to take, So that's again very important. So things have impacted us seriously. So we have to think fast and do something to overcome the hurdles and provide the best services for our patients. And we have to evaluate the fellowship education, the training we want to provide. So before the pandemic, there was a good amount of caseload, Sami knows that. And then with the pandemic, the caseload is less. So we have still fellows in training, the future consultants, they need to be trained as well in order to provide the proper training and proper good services to their patients. So as you say that you all say that big things can come from a small idea. Like today, we are talking on Zoom. So the Zoom, it provided a platform for a virtual meeting. So it provided an opportunity. This COVID provided an opportunity for us to better deliver the healthcare behind the doors, with the curtains down. We'll still be able to provide the patients the services they deserve, and what can we do to improve things for them. It was a learning experience. We are still in the learning experience, but it really spurred changes in our behavior, and we decided that we need to go tech. So we need to employ technology in order to provide the better healthcare to our patients and to serve our patients better. So we replaced from inpatient services to virtual clinics. So we started with the virtual. We moved where it was allowed, not like UK where it's only in NHS, but in countries where there are private hospitals, or the small surgery centers. So the elective surgery moved from big hospitals into small surgery centers. As what Sami said, Wallant, like daycare surgery, highly popularized during this period. People prefer not to give general anesthesia and to have something done then and there and go home, be admitted in the morning, have the surgery in the afternoon and go home the same day, no overnight stay, probably in a small private setup, so they don't have the risk of catching COVID from other patients. So this shift was there. And then there was increased pressure on us to be more cost effective and to strictly follow what we call is evidence-based medicine guidelines, and to really prioritize patients who would need elective surgery. We are not talking about trauma, but we really need to prioritize or get our priorities correct during this pandemic. So the impact of telehealth and virtual visits, the biggest example of change associated with the coronavirus outbreak, early encouraging evidence, particularly for shoulder surgeries, that we could do post-op if we use kind of dissolvable stitches or no stitches or something. We can do an online consultation. We can start online visits. We can look at the wound. We can advise patients regarding the dressing. We can do prescription online, and they can go and buy their medicines. And this telehealth, I must say, is going to stay and will become the norm of orthopedic surgery. And this is the new normal, the rapid adaptation of the telemedicine, again published in Injury in last December, where the patient were happy. That the most important among in healthcare delivery is the patient. The patient-reported outcome measures were very good. Patients were very happy. They missed the in-person consultation, but they are still happy to receive an online consultation. So there is a need for all the major hospitals to set up every clinic, a virtual clinic setup. So you might be able to reduce the workload, provide the same quality of care. There are certain qualms about it. We'll discuss it later. But yeah, this is something that is going to stay and that is going to change the face of orthopedics. And what about the follow-ups and the shift of telemedicine on patient-reported outcomes, which could be validated? And as I mentioned, there's absolutely no difference in the patient-reported outcome measures when we compare from inpatient to virtual health clinics. So
Dr. Yasser, can you hear us?
and videos are very helpful. And if you go onto YouTube, you would now see many videos, even I put videos from my clinic, from YK Orthopaedic, on our YouTube channel. And we discuss about frozen shoulders and simple exercises you can do. So you could go and watch those ones as well. So yeah, I mean, it is there with this pandemic. We all need to adopt. And then we have different companies coming up. And we are collaborating with those companies to assess the post-operative recovery. There are one in USA, I've just put it here, is myhealthtrack.com, and the other one is postopqrs.com from London. So these companies are there to provide a very good tool for the surgeons to do their post-op assessment. So it is there, it's going to say, we have also education, like the one we are doing now. We are on Zoom. We are providing the valuable information to our mass media. So the virtual clinics, the virtual conferences, there is less and less hands-on training, unfortunately. But the tools are there. The mannequins are there. So you could learn everything from videos and online sharing tools, and you can provide as good education as possible during this pandemic to your residents and fellows. So there is still hope for them as well to become good surgeons and be good for their patients as well. As I mentioned, that there is a greater shift in surgery from hospital to surgery centers, and mainly because people and even the surgeons themselves are afraid of catching COVID from a big hospital. So yes, there is there, and more you would see in future in countries where it is allowed to have these small centers will pop up, and it certainly will help the delivery for orthopedic services to these patients. Evidence-based, and that is very important. In orthopedic surgery, we basically do surgeries more based on more anecdotal than empirical evidence. What I mean by that is they're still doing, arthroscopic debridement for the knee for knee osteoarthritis, which is absolutely no need for it. So, but we still do it. Patient likes it. Patient wants it. But now we have to be more strict towards who we can offer elective surgery in during this pandemic, and what can be managed non-operatively with the help of medicine and physical therapy. So we need to be a little bit more stricter in our cases we are selecting to go for elective surgery. So the change, this was on clinical orthopedic research, the clinicians consider implementing telehealth strategies, high quality care for patients, and protect the workforce during a pandemic. They showed a successful implementation of telehealth for a diverse orthopedic trauma population that historically has issues with mobility and follow-up, and future studies certainly required, because these can still miss infection. It's not easy, if you don't have a good connection, or you have a problem with the camera, you cannot see an infection. You could miss an infection. So that is a concern. There is with the physical therapy, you have a concern that regarding the stiffness. particularly like shoulder and elbow and wrist. We don't want them to get stiff, no major joint. So that is still is a concern on telehealth consultation. But we hope and sincerely hope that there will be tools that will help us to assess and guide our patients better, as long as we have this facility available. And we can still, under this situation, if there's any doubt, we can call this patient up for one-to-one visit if patient agrees, and assess for the infection and treat the infection or treat the stiffness in the shoulder. So, well, as I said, that the patient needs to be happy with it, and the patient-reported outcome measures are very good, and they're very happy, and it's been reported as well, as recently as last January. So yes, patients are happy. So in conclusion, creative thinking will be needed to accelerate progress after this outbreak, and innovation is critical to create future evidence. This pandemic is the best step at some of the unexpected ways that orthopedic surgery may change for the good. And for too long, telehealth care has been an idol for the inefficient use of time and resources. The future may not permit. But in the end, we are still in the pandemic, so keep wearing your mask, no handshakes, and get your vaccination done as soon as possible. Thank you, everyone.
That's great. Let me just wait for Dr. Yasir to stop sharing. Yeah, thank you very much, Dr. Yasir. What I'll tell you that you should go and do your iftari now, because there are just few minutes left, and you have given a very long
Yes.
long thing. So we will leave the questions for you. I will email you the questions, whatever I have received it. So thank you very much.
Okay, fair enough. Thank you very much, everyone.
Yeah, exactly. You go and do your iftari, because it's a long roza. So thank you very much, Dr. Yasir, from my side.
Thank you very much.
From Apps Europe, from NODFA. Thanks a lot. So you go. So
thank you, Yaran Watan. Thank you, Kashif and Sami. Thank you. Thanks very much, guys.
Thank you. Thanks. So it brings back to me to Dr. Sami Hassan regarding few questions which I've received. So I will put those questions to you. So Dr. Yasir has given a very interesting, figures that, in British Columbia, 32,400, are cancelled. And it also, said that in UK, there is a reduction in 91% and also 55% in clinical, setting. There is one of the questions which has just been sent to me, that with those kind of, long cancellation, how the UK or the orthopedic departments of UK can cope with this, deficit, that how they can overcome with so many waiting patients who needs the surgery.
Many thanks, Kashif. I think it's a very interesting question. It's actually the million-dollar question. How do we reset going back to catch up from the backlog, the elective services? It's a very tricky question. The current ground reality problems are that hospitals are in the process of resetting back, getting their theatres back, reconverting the pods which have been used in theatres for intensive care purposes, finding zones in different parts of hospitals to enable patients to be safe to come in for their surgery. This process is ongoing. Once this is all teed up and sorted out, the way forward essentially would be that there will be a massive backlog of patients waiting for routine operations, hips and knees, and essentially speaking, there will be added lists put on weekends, evenings, theatre space will be optimized, timing will be pushed, and therefore there will be an effort towards efficiency, trying to use what they initially wanted to do, the government, a 7-day NHS, which we all know is already present and working absolutely fine, to catch up this massive backlog. We do have to bear in mind that, every region has outstanding elective issues, and Recently hearing there's one thing in hospitals where we work, there's a huge backlog of echocardiograms, and to get those done as well on weekends, to get various other subspecialty elective work done, investigations done, non-routine scans done. There's a huge sort of concerted effort to go on to re-establish normality and to work through those patterns of problems. The other problem we all have to think about is all our allied healthcare professionals, the nurses who've been redeployed and helping. It's a very difficult time that they've gone through as well, and the energy required to go back and work even harder to make sure that we compensate for issues such as massive waiting lists is going to be a big burden on them, and I think finance and time will play a role, and I'm sure surely and slowly we'll start becoming normalizing and back working through these big waiting lists.
Thank you very much, Sami. This is a very nice and descriptive answer. The other question I've received is they say that how important is telemedicine? Can they play any role in covering those fallbacks or anything which can be helpful in orthopedics? So what is the role of telemedicine in COVID and orthopedics? This is the question.
I think telemedicine and virtual consultations is the new norm now, and I think it has massive amount of benefits. In the trauma setting, we can check on how patients are rehabilitating post-surgery. We can watch videos of them. For example, in hand surgery, the hand therapist can show them through a video link. Nothing, in my personal opinion, will be as good as seeing patients face-to-face. But I think it's an efficient way of seeing patients. It's an efficient, safe way of seeing patients, even from your own house. In orthopedics, unfortunately, I still have fracture clinics worth of 30 patients face-to-face that I see on a week-to-week basis. And in those clinics, there still is a need to examine patients, palpate joints, work out what's going on, send them for immediate investigations. But the telemedicine provides a great point of triage, and at times a telephone call prior to their appointment, working out what's their history, gauging what we can find from their symptoms, sort of coordinating a virtual examination may save them possibly a visit to hospital, may streamline their appointment better because we may be able to request investigations prior to them turning up to hospital. And instead of turning up 2 or 3 times, we may just make that appointment a one visit appointment, which, and I think that's a great thing to do. And I think as we come out of this pandemic, it's something such as telemedicine, virtual consultations and working from home, which will have revolutionized medicine in the coming days.
Thank you very much, Sami, which takes me to another question that has COVID changed your clinical practice?
Yeah, it has. As a hand surgeon, we're pretty well adapted to doing day case surgery. We have the mini C-arm. Practice-wise, I think I'll be doing quite a lot more wide awake, or be more braver to be a wide awake surgeon using local anesthetics. I've got colleagues that have fixed lots of fractures through wide awake surgery. I've got colleagues that fix distal radiuses, and that's the next step. But I think that there has to be a big change in patient education in that, a lot of conversation with patients and into discussing, having no sort of what they refer to as an anesthetic or a general anesthetic, and going down the local anesthetic route. And I think that's something that I will be establishing more and more as I progress through my career many down the line.
Thanks, Sami, for that one. Also now, the other question which pops up that, and I agree with that question, that COVID is not going to go away. It's going to stay for a, very, very long time. And the figures which are shown on the international journals in British Columbia and the UK and everything, that the orthopedic surgery has hit very badly, with the fact that the old people are more prone to have a COVID, symptoms. How do you see that, going forward, that the long-term effects of COVID on patients with orthopedic problems who needs surgery earlier rather than late, but then they are been repeatedly being cancelled due to COVID?
I think it's a real tricky problem, and we're experiencing that now. We've had fault storms of restarting elective practices, repeat lockdowns in the United Kingdom, probably worldwide. And patients have been given appointments or dates for surgeries, and sadly they've been cancelled. And I think we will never, as long as COVID's there and the threat of lockdown and still vaccination programs still to carry on, I think we'll always have that threat of cancellation. How we deal with it becomes a logistic issue. I think patients, first of all, being vaccinated, that always helps. Having swabbing for COVID-19 available prior to surgery, isolating, having protocols and SOPs in place, and having different zones like gold zones and blue zones and green zones and red zones within the hospital, they will allow patients to have a safer journey. Now, it is sad that there are the elderly population that are struggling, but it's not for the want of us trying to operate. It's just we all sadly have to accept the point that this is now the new norm. Not only in the NHS, this has also affected private work as well. So for consultants who do solely private work or private work, the private hospitals have been kind enough to develop contracts with the NHS to outsource cancer work, other work that is a priority, should I say, a 2-week priority list type work. And therefore, people wanting to expedite their appointment and be willing to pay, for example, in the United Kingdom, they're struggling to get appointments and places in theatre due to the fact of this joint venture and trying to give patients who are most vulnerable the safest operation.
That's a very nicely answered, Dr. Sami Hassan. So I think so. This brings us to the end of our session, and because we try to run the session for about an hour's time, so that it should not prolong, and the people should attend it with an interest. So I'd really like to thank you, Dr. Sami Hassan, for your valuable time. I know you just been to football, practice, and you were coaching the football team, and then you're an orthopedic surgeon.
Yeah, we won, so that's always a good thing. 9-3, so the children won, so that's very good.
That's very good, very good. So thank you very much once again. And this session will be is recorded, and it will be put on Facebook as well as on YouTube and other social medias. So if anybody wants to see the session again, they are more than welcome to see it. So thank you very much, everyone. Thanks a lot. And inshallah, I'll come back to you with another teaching session. Thank you, everyone.